Hello, welcome to Tropia Medic School. Today we're talking about airway basics, so all of our questions will be on EMT and paramedic related airway interventions and some other information. Like and subscribe if you like this content, and let's get started. So first question, which of the following is the most common airway obstruction? A, foreign bodies, B, teeth, C, tongue, or D, the epiglottis. And you can take a second to pick an answer. And if you picked tongue, you would be correct. The tongue is the number one obstruction in the airway. Not necessarily a full airway obstruction, but when you hear the words like snoring respirations, oh, let's choose a different color there. That's an awful color. When you hear the word snoring respirations, we know that the tongue is creating some problems. Again, not necessarily complete airway obstruction, but in a lot of situations, this can certainly make things more difficult. All right, let's move on to the next question. All right, so you have an unresponsive patient with a carotid pulse and snoring respirations. You note no trauma. You should A, start CPR, B, perform a head tilt chin lift, C, perform a jaw thrust maneuver, or D, administer BVM ventilations. So take a moment. And if we picked perform a head tilt chin lift, that's a great start. So they told us that they have a pulse, so that's good. We can get rid of A. C, jaw thrust maneuver. So as kind of a refresher here, when we talk about head tilt chin lift, this is our number one preferred airway maneuver when it comes to just opening the airway. So if you just need to get the airway open to stop those snoring respirations or whatnot, head tilt chin lift is preferred. Keep in mind, however, that you do not want to do it when we suspect C-spine trauma or if there's a C-spine issue related thing going on. So we're not going to do the head tilt chin lift with C-spine related issues. Instead, if we had a C-spine related issue, we would do jaw thrust maneuver. We'll put that in green. So I would want to do this if there was a C-spine issue. Now that said, it's not as effective as the head tilt chin lift. So again, we reserve it more for those trauma patients, but it can work if you needed to with a C-spine injury. BVM ventilations, before we get to the ventilatory aspect of this, we should address the airway. Remember, we like to do things A, B, C, airway, breathing, circulation. So although BVM ventilations are something we may have to do, we don't have anything telling us that they are only intermittently breathing or anything like that. That's not going to be our first step. So we can get rid of all those other answers. And let's now move on. Oops. All right. Uh-oh, it seems to, we gotta put that back. There we go, that's easier to see. Your patient is responsive to painful stimuli and has snoring respirations. You should A, insert an NPA, B, insert an OPA, C, suction the patient, or D, apply a non-rebreather mask. So take a moment to think about your answer. And we're going to pick insert an NPA. Why is that? So the OPA, we'll start off with talking about the OPA. This is our number one airway adjunct. This is what we prefer to use. Airway adjunct. We prefer to use the OPA because it's going to keep the tongue out of the way. That is our preference whenever we're dealing with airway stuff. It'll make it easier to suction. It'll make it easier to BVM. However, they have to be unresponsive, generally speaking. And they generally have to have no gag reflex. Now here they indicate that this patient is responsive to painful stimuli. And so generally speaking, when we see that, we know that they more often than not will still have a gag reflex because their brain is not completely offline. So I can't really shove something down their throat when they have a gag reflex. Doesn't seem particularly chill to do. So B, kind of out. We can get rid of B. Suction the patient. They don't tell us anything about gurgling or secretions or blood in the airway or anything like that. So we don't need to suction them just yet. And without addressing any of the airway stuff, we can't really do much in the ways of oxygenating. If they were alert, had difficulty breathing, controlled their own airway, cool. That would work fine, but we can't jump to that until we solve the airway issue. The MPA is a fantastic tool for a couple reasons. One, I can use it if they have a gag reflex, so they don't need to be completely offline. So as an example, when I went through my combat medic school for the Army many, many years ago, everyone had to have an NPA or nasopharyngeal airway inserted into them. And I'm not saying it's fun, because it's not, but you can be fully conscious and have one put in. So their brains don't need to be completely offline. They can still have a gag reflex. However, something very important to note, we cannot do it if there is facial trauma or if we have signs of a basilar skull fracture or a Lefort fracture. We'll talk about that at some other point here. Skull fracture. So when they have facial trauma, don't use the OPA. Or sorry, don't use the MPA. OPA you can use with facial trauma. That's fine. All right, let's move on here. Next question. You have an unresponsive patient with secretions in their airway. You should A, suction until all the secretions are clear. B, administer BVM ventilations. C, insert an endotracheal tube. Or D, suction for up to 15 seconds. So take a moment, pick an answer, and we are going to suction for up to 15 seconds. Starting with A, although in real life maybe there's some gray area, we don't want to just simply suction, and suction into infinity. Let's talk about some stuff with suctioning. So obviously suctioning is important to get stuff out of the airway to clear it up, keep things from going down the lungs. However, some things with suctioning is that we can induce hypoxia, right? Because we're suctioning stuff out of the airway and respiratory tract, particularly in kids. We can induce hypoxia with prolonged suctioning. Another thing is that we can also induce atelectasis. Wow, that's a fancy word. What does that mean? What happens here is that the alveoli can collapse in on themselves. They kind of lose their shape. We're suctioning everything out of them. They just kind of, glue themselves shut. And we're going to have to pop them open. And when we pop them open, it takes a little while to pop them all open. Really easy to collapse them, a little bit harder to pop them back open. So we don't want to induce this in our patients. So this is, again, another reason why, if we can avoid it, we don't suction them into infinity. So before addressing our ventilatory issues, right, I don't want to just simply BVM ventilate them and just push all these secretions down into their respiratory tract. That doesn't seem very good. And a good rule of thumb is if it's not in your scope of practice to do, don't do it, right? So we know that endotracheal intubation is not it's a paramedic skill, right? We can't do it at the EMT or in many states at the AEMT level either. So just keep that in mind if you're testing at the EMT basic level. Don't let them fool you into picking an intervention that is not in your scope of practice to do. So we're just going to suction for up to 15 seconds. If we need to, we can try to oxygenate them again and then go back at it if we need to. In real life, there may be more gray area. I'm not saying that there isn't, but for testing purposes, suction for up to 10 to 15 seconds. All right, moving on. Your unresponsive patient has battle sign and periorbital ecchymosis after an altercation. Which of the following is contraindicated? A, an OPA, B, jaw thrust maneuver, C, NPA, or D, head tilt, should say head tilt, not head tilt, head tilt chin lift maneuver. So take a moment to think about an answer. Let me see if I can change that. Head tilt, look at that. All right, so if we picked NPA, you'd be correct. The question here is asking which of the following is contraindicated. This is what we call the root question, what's actually being asked of us. So they're asking one of these things we can't do, which one is it? A testing technique to keep in mind for some people that works really well is look, instead of reading the whole thing, first look for what is the root question, what's being asked of you, and then you can circle back to either your answers or read the question in its entirety, and that might help you understand what is being asked of you and what you need to be on the lookout for. Now, we talked about the NPA we cannot use in facial trauma. We mentioned that here already. No facial trauma. If you got bashed in the face, don't do this. What tells us here that they got bashed in the face? So periorbital ecchymosis and battle sign. Battle sign is bruising behind the ears. So battle sign is bruising behind the ears. And this is a sign of a basilar skull fracture. Meaning that think of the base plate, if you will, of your skull is broken. FX for short for fracture. Periorbital ecchymosis, this is what we oftentimes call raccoon eyes. And this is oftentimes a sign of what we would call a Lefort fracture. At the EMT level, you don't need to be too familiar with that. Just know that it's a fracture of certain bones in your face. Zygomatic bones would be one of the potentially affected ones. The nasal bones, the sphenoid, the ethmoid bones. We don't need to go into more detail than that. Just know that your face done got screwed up. So if we see bilateral raccoon eyes, not a good thing to mix in the NPA with. Actually, there's two answers here. If you picked head tilt chin lift, you know what? That would be a good answer too. Well, I guess you got a freebie there. Yeah, head tilt chin lift would be contraindicated as well because we're manipulating the C-spine. So if they got their head, if they have head trauma, we should assume that there's C-spine trauma. So we're going to just take C-spine precautions regardless. Nice. Let's look at our last question here. All right, which of the following signs or symptoms would indicate an airway emergency? A, stridor, B, angioedema, C, muffled voice, or D, all of the above. Take a moment. And if you picked all of the above, good work. All of these things are potential signs of a airway related emergency. So stridor, we mentioned this in the last video. Stridor is this high pitched inspiratory sound. And this is a sound where it's kind of like when you blow across a narrow aperture, super high pitched. Same thing's happening in your airway. So high pitched, and it's going to be on inspiration most commonly. Angioedema, this is what's associated with anaphylaxis. And this is things like the facial swelling we associate with anaphylaxis. We see throat swelling as well, so swelling up of the mucosa membranes and the structures of the airway. So obviously that can create airway compromise. We know anaphylaxis or severe allergic reaction can potentially create a complete airway obstruction. Muffled voice, this is an interesting one. So when we think of muffled voice, there's a number of things that can cause this. We can have, pharyngeal infections, tonsillar abscesses, but one thing to note in particularly burn questions, we may have burns to the airway with a muffled voice. If they mention other things like soot around the mouth and the nose, they have, they show signs of like flushed skin, related to like a structure fire or something like that, right? We should assume, or singed hairs is another one. We should start thinking, okay, they inhaled a lot of hot gases. Maybe they have an airway burn too. And the problem with airway burns is that burned tissue swells up and it doesn't just simply unswell, if you will. So definitely it can get very bad very quickly. So all of the above are going to be airway related things that should really, really concern us. That is all of our questions for this video. Again, if you like the content, like and subscribe. Let me know if there are other things you want to cover, and we'll see you next time.